Thank you. It's a great honor to stand before you today to talk to you about GP120 again, to talk to you about maybe trying to see GP120 as a potential personalized medicine target to curb ongoing systemic inflammation in people living with HIV. So first, this should probably read acknowledgement as well on the slide, but I do want to disclose that I'm in the process of running a collaborative study with Vive Healthcare, which is the study that I will be discussing today. And very importantly, I'm a clinician and epidemiologist. The basic science work that will be presented today is the work of Andrés Finzi and his collaborators. And the clinical trial that I will be discussing today has been co-designed by a community advisory board. So I stand here on their shoulders, and it's an honor for me to present our collective work. So again, another way of seeing what we've talked about, we know that the gap in life expectancy remains for people living with HIV, but has been closing encouragingly in the past 20 years. What has not been closing and what we have not been good at addressing is the gap in comorbidity-free life expectancy. So, on average, and the word average is important here because there is great heterogeneity with aging in general, with aging with HIV in particular. But on average, people living with HIV today can still expect to develop their first comorbidity 15 years earlier than people without HIV. And we stand at an interesting crossroad this year with the HIV pandemic, as many people are living on the planet with HIV today as have died of AIDS since the beginning of the pandemic, and that is roughly 40 million people. So living with HIV is very important, and living well. WHO has a staggering estimate that, as we speak today, 0.7% of all adults aged between 15 and 49 years are living with HIV and are at increased risk of premature comorbidities. Now, do use the figures from the other presentation for causes of early comorbidities, because they were much more apt with PowerPoint than I am, and this is a much simplified version. But why do we have early comorbidities in HIV? Many reasons, of course. Traditional risk factors, of course, immensely important. ARVs have had terrible and still have side effects, but I'm going to argue here that we have come out of a very dark tunnel in terms of ARV side effects. So much so that we can now focus on sort of the elephant in the room, which is the viral persistence in the body, which is driving chronic inflammation, depletion of gut, and immune dysfunction. So the one piece of viral persistence that I want to address today is glycoprotein 120, the attachment molecule to the human CD4 receptor. And for this, I refer to the work of Andrés Finzi, who has put forward the hypothesis that GP120, which is known to be shed from HIV-infected cells, to be shed from HIV virus, can actually represents a toxin that drives inflammation and immune dysfunction, and this can happen even when viral load is suppressed. This is, I met Andrés Finzi, who shared this hypothesis with me roughly 2 years ago now. I am the principal investigator of the Canadian HIV and Aging cohort study, a cohort that was started by Cécile Tremblay, my mentor and at the time postdoc supervisor, back in 2012. The cohort is one of your typical HIV and Aging cohort studies. We enroll people 40 years and over, we follow them rather loosely every 2 years. We collect clinical outcomes, we collect a biobank, and, excuse me, in a subset of participants, we conduct cardiac CT scans to quantify and qualify their cardiovascular disease. So when Andrés approached me and told me I will detect GP120 in the plasma of people from your cohort, and I said, no way, these people have been undetectable for a median of 15 years. You will not find any remnants of virus in their plasma. So we identified 368 participants from the cohort, and he performed his homemade ELISA and detected, to my surprise, soluble GP120 in up to a third of the participants. What was even more striking to me is that the levels of GP120 were correlated with levels of interleukin-6. Now, they have very elegantly shown in their 2023 Cell chem biology paper that GP120 in vitro can link to the CD4 receptors on HIV uninfected CD4s, and then can mediate ADCC, antibody-dependent cellular cytotoxicity, via the role of the anti-cluster A antibodies that recognize the bond between GP120 and the CD4 receptor, leading to the killing of HIV uninfected cells. So we wanted to know if there would be a correlation in vivo in samples from the cohort of this dynamic that was elegantly showed in vitro. And so in the entire group of 386 participants, there was a weak association between the level of anti-cluster A antibodies and a decline in CD4s. And the same dynamic was seen for the CD4-CD8 ratio, but I'm not showing this data. But what was perhaps most interesting to me was the fact that when we stratified by levels of GP120, the association was much more pronounced in the people that had the higher levels of GP120. So this seemed to be in favor in confirming the dynamic observed in vitro in a cross-sectional analysis of the Canadian HIV and aging cohort study. Perhaps even more interesting for an internist like me, when we looked at the subset of patients for whom we had cardiac imaging, we found that the combination of the anti-cluster A antibodies and GP120 was associated with the size of the coronary artery plaque found in the heart of these patients. The silver lining to this study, and where I'm trying to convince this audience that there might be something very interesting there, is that Andres and Jonathan have also shown that the deleterious pro-inflammatory, pro-immune dysfunction effects of soluble GP120 can be curbed. When you add to the cell culture temsavir, which, as you know, is the active element in HIV attachment inhibitor fostemsavir, an oral ARV drug that is well tolerated, that is presently approved for treatment of resistant HIV viruses. And so the question that begs to be answered is, can fostemsavir help curb systemic inflammation in people that have it detectable in their plasma? And so, in collaborations with a group of people living with HIV, our community advisory board, we have designed a randomized control trial, which is called the RESTART study, to precisely look at that hypothesis. And I'm happy to announce that this trial was actually funded by the Canadian government on July 9th. So we're excited to be moving into the active phase of this study. The study hypothesis is that people that are living with HIV with an undetectable HIV viral load, but with detectable soluble GP120 in their plasma, are exposed through GP120 to chronic inflammation, sustained immune dysfunction, and increased risk of comorbidity. And that if we strengthen the ARV regimen with fostemsavir, this will curb those deleterious effects and hopefully curb some of the inflammation-associated risk of comorbidity. And so the study objectives we had, of course, were to conduct this trial, sustain the trial-associated biobank. We also wanted to give special effort to have a good representation of women to this trial, as well as co-design this trial with the community, because we are talking about yet another pill, and we wanted to make sure that this could align with the objectives of people living with HIV. This is an overview of the design. So this is a randomized parallel arm, open label, and with blinded outcome assessment trial. This is a rather small trial because it's a proof of concept in human, so it is not powered to look at hard clinical endpoints. We are aiming to recruit 75 participants per group. The inclusion criteria are to be 40 or over, or having lived with HIV for 25 years or more. And this was added because participants to our community advisory board that had been born with HIV found it important, as they have been exposed lifelong to this virus, that they could have access to this trial before their 40th birthday. So the intervention is fostemsavir, 600 milligrams per day versus standard of care for 24 months. We will be biobanking individuals at every study visit, as well as performing cardiac CT scans at the beginning and end of the study. The primary outcomes are imaging outcomes. So the primary will be the change in the total volume of non-calcified coronary artery plaque. So as you know, the non-calcified plaque is the soft component of the atherosclerotic plaque. It's more pro-inflammatory, it's more prone to rupturing and causing acute myocardial infarction. And it is the component that can fluctuate with treatment, as it is not yet calcified and thus has more chances of healing. Secondary outcomes include pericoronary fat attenuation, and I'm just going to say a couple words about this one, which is sort of a novel imaging biomarker for heart disease, as well as biomarkers and, of course, clinical endpoints. So I just want to say a couple words about pericoronary fat attenuation index. I think that this is a marker we need to look out for in HIV. So what this is basically is that you take the CT images and you look at the region of fat tissue that surrounds the coronary arteries, and you look at its attenuation. Attenuation, basically what it means is just a scale of gray on CT. And the higher the attenuation, the more inflammation, the increased cardiovascular risk. Why is this an important biomarker? Because it's sensitive to inflammation. And we believe that it is through inflammation that HIV is an additional risk factor for cardiovascular disease. This biomarker has been shown to predict acute coronary events, even after taking into account all traditional cardiovascular risk factors and the size and characteristics of the plaques as seen on CT. It has also been found in people living with HIV to correlate with circulatory inflammatory biomarkers. So we'll look at that in the RESTART trial. This is just sort of a cartoon overview of the study design, but basically repeating what I've said before. So it shows you the eligibility period, the intervention, which is going to be 24 months, as well as a washout period, because we want to see what happens after we stop fostemsavir, with the cardiac CT scans at enrollment and end of study. There will be a trial-associated biobank. Some pre-specified biomarkers have been identified, but obviously more can be done as well with the biobank. Just a word about recruitment of women. Women form 54% of people living with HIV worldwide, but have been traditionally underrepresented in research to the point where it might invalidate some of our scientific conclusions. As we know, women have a different immune system with tremendous challenges before and after menopause. It is not easy to reach women for clinical trials, definitely in my setting in Canada. So we are trying to do better. In the Canadian HIV and aging cohort, there's less than 10% women, which is something we are not proud of and trying to improve. So what we did is that we basically enrolled women living with HIV that have a vast experience of research, experienced researchers. We budgeted for different things for visits, such as child and elder care, opened out-of-hours visit, we will train all study personnel in the women-centered model of care that has been put forward by co-researcher Mona Lutfi. And hopefully this can help us reach 50% so we can have the most power possible, even though the study is small, to look at effect modification by sex. And I would be remiss before I start not to acknowledge the tremendous work that the Community Advisory Board has put towards co-designing this study. Our Community Advisory Board is formed of 7 people living with HIV, representative of diversity. They have been involved throughout. They have digested the basic science in a beautiful way. They have co-designed the trial and will have an active role moving forward on every critical aspect of the study by all of the elements that are listed on this slide. So in summary, we have shown with Andres Finzi's ELISA that GP120 is detectable in up to 1/3 of people living with HIV, possibly marking it as a target, as a precision medicine strategy, where maybe for these people we need to do more than just suppress the HIV plasma viral load if we are to curb the risk of inflammation-related comorbidities. Andres has shown in the cross-sectional analysis of people from the cohort that those that have higher levels of GP120 have more inflammation and more immune dysfunction. Now, whether addition of fostemsavir will be able to curb that inflammation, whether that proportion of inflammation compared to the very complex milieu of the human body will be meaningful. This is all left to prove. This is what the RESTART study is out to determine. And hopefully we will be having answers in the coming years. This is the RESTART study team, and in closing, I would like to deeply thank all members of our labs, everybody recruiting in the aging study, our funders, and of course participants to the studies.